all the way from across town at Hopkins. She received her BS in biology at Davidson College. Is Atkins here? Didn't you go to Davidson? Go Davidson! And her medical degree from Washington University in St. Louis. During medical school, she was the recipient of the prestigious Howard Hughes Medical Institute Fellowship and spent a year at the NIH performing basic laboratory research. She completed her residency in psychiatry at Johns Hopkins, where she served as chief resident during her last year. Dr. Payne then completed a fellowship in mood disorders through the Mood and Anxiety Disorders Program at, is this supposed to be NIH? This is NIMH of mental health. Okay.
Yeah,
okay.
NIMH.
There's an extra M. Okay, the NIMH at NIH. Sorry, I wasn't sure if I had a typo. Dr. Payne joined Johns Hopkins faculty as an assistant professor in 2003 and was promoted to an associate professor in 2011. Since her return to Hopkins, she has developed 2 programs, both aimed at understanding the pathophysiology of underlying mood disorders, which is why she's here with us today. Dr. Payne is the director of the Women's Mood Disorder Center, and in addition to providing outstanding clinical care for women with mood disorders, she conducts research in genetic, biologic, and environmental factors involved in postpartum depression. She and her colleagues have recently identified epigenetic biomarkers of postpartum depression and are working hard to replicate this work. Dr. Payne also directs the Mood Disorders Clinical Trials Group with the goal of developing novel therapeutic treatments for depression and bipolar disorder. She's been awarded a number of honors, including the Pisano Physician Scientist Award, the NARSAD Young Investigator Award, and has been named a Distinguished Fellow by the American Psychiatric Association. I met Dr. Payne through the Maternal Mental Health Coalition that was started by the governor to identify needs for women's mental health in Maryland. And I'm very excited for her to be here today talking to us about her work and mood disorders for women.
I always forget what's in that biography. I think I need to shorten it, so sorry about that. So I'm here to talk to you primarily about the management of mood disorders during pregnancy. There is a ton of misinformation floating around out there, and my goal for you is to dispel many of those myths today. Now, all right, so let's talk about what this got. Okay. So this is the talk overview. First, we're going to talk about how common mood disorders are during and after pregnancy, and why we actually think it's quite important to treat mood disorders. I think a lot of people think, oh, depression, you can muddle through a pregnancy and be depressed and it will be okay. And the problem with that is that it's actually an exposure for the infant. It affects infant outcomes as well as outcomes for the mother. And then I'm going to kind of go through my rules for medication management during pregnancy for a psychiatrist. And we'll talk specifically with antidepressants about persistent pulmonary hypertension and poor neonatal adaptation syndrome. And then I'll briefly talk on mood stabilizing medications for bipolar disorder. So in terms of major depression, there's really no evidence that the risk of major depression is increased or decreased during pregnancy. When I first started residency a long time ago, pregnancy was kind of thought of as a protective factor against major depression, but it turns out that's not true. The risk of a major depressive episode is about the same during pregnancy as at any other time in a woman's life. And so even though there's no increased risk, there's no decreased risk. In contrast, the postpartum time period is really the only time that we can predict that a certain percentage of the population is going to get ill with depression and when they're going to get ill. So this was a nice study. This was the National Epidemiological Survey on Alcohol and Related Conditions. This was conducted in 2002, and it interviewed over 14,000 women who'd had a pregnancy in the past year. And basically, they confirmed that there was no increased risk during pregnancy, but found that the postpartum time period, which is about the first 4 to 6 weeks after delivery, had an increased risk of depression. However, if a woman has a pre-existing history of major depression and she stops her medications for pregnancy, she has about a 60 to 70% chance of relapsing with depression during pregnancy. So this is data from kind of a study that we quote all the time by Lee Cohen. It was published in JAMA in 2006, and it's based on a fairly small sample of 200-some women. But they found that women who stopped their medications, about 60 to 70% would relapse and become depressed again during pregnancy. Now, back in 2006, we were recommending that women stop their antidepressants for the first trimester. And this really changed things because what we found was that most women were relapsing. We were then restarting medications. And so then we were exposing the baby to both the major depressive episode as well as the medication. So at this time, we do not recommend stopping medications for the first trimester. In pregnant women with bipolar disorder, it's pretty much the same story. There's no increased risk for relapse during pregnancy, but the postpartum time period is a very risky time period. Most women with bipolar disorder will have a major depressive episode in the postpartum time period, but occasionally we will get women who will become manic or hypomanic in the postpartum time period. And in addition, there's an even higher rate of relapse if you stop a woman's medications for bipolar disorder. So this is a particular study that showed that 85.5% of women who discontinued their mood stabilizer for pregnancy relapsed with some sort of mood episode during pregnancy. Compared to only 37% who continued their mood stabilizer during pregnancy. Now, we prefer that 37% would not relapse. Part of what happens during pregnancy, as you well know, is the blood volume increases, liver metabolism increases, and blood levels of mood stabilizers tend to drop over the course of pregnancy. And so in that setting, about a third of women will relapse. So we really strongly recommend monitoring women's blood levels of mood stabilizing medications during pregnancy. So even though pregnancy is technically risk neutral, if you take women with a pre-existing mood disorder of either major depression or bipolar disorder, they have a very high relapse rate when we stop their medications for pregnancy. And in addition, the postpartum time period is a clear increased risk of either depression or mania in patients with bipolar disorder. So why do we care about treating particularly depression during pregnancy? I have many patients who come to me and say, well, you know, my depression is not great, but I could get through 9 months of it if I had to for the sake of my baby. Well, actually, when women are depressed during pregnancy, it turns out that that affects the outcomes for the infants as well. So being depressed during pregnancy has been associated with preterm birth, low birth weight, decreased motor tone and activity in the baby. There are higher cortisol levels in infants that were born to mothers who were depressed during pregnancy, and those elevated cortisol levels appear to persist into adolescence. And if you read the basic science literature, we think that that might be associated with an increased risk of anxiety and mood disorders. Poor reflexes in the baby, and in addition, ADHD has actually been associated with mom being depressed during pregnancy, particularly in boys. Also, depression during pregnancy is one of the biggest risk factors for postpartum depression. It kind of makes sense. If you're depressed during pregnancy, you're likely to be depressed after delivery. And there is a robust literature showing poor outcomes for infants whose mothers are depressed in the immediate postpartum time period. So we know that postpartum depression is associated even with lower IQ and slower language development. And that's because the mothers don't respond and interact with their babies in the same way. They don't attach to their babies. They don't talk in a high-pitched voice, and they're not in their face. They leave them alone. And so this has significant effects on their IQ and language development. It increases the risk for ADHD and behavioral problems and psychiatric illness in the infants over the long term. So in addition to that, suicide is a major cause of maternal death in pregnancy and accounts for up to 20% of all postpartum deaths. And I know that you guys are all working really hard at preventing postpartum deaths, and it's kind of shocking to me that suicide accounts for 20% of all postpartum deaths. And psychiatric disorders in general are the leading cause of indirect maternal deaths. Now, suicide is a rare event during pregnancy, but it still accounts for a huge percentage of the deaths that occur surrounding pregnancy. So let's talk a little bit about how I come up with a treatment plan for women who have mood disorders, who are either contemplating pregnancy or are already pregnant. So rule number one, I think you guys will like this. I tell people all the time, you have to assume that all women of reproductive age will get pregnant. And as you know, 50% of pregnancies in the United States are still unplanned, which still blows my mind. But when a psychiatrist prescribes the medication to a woman of childbearing age, I really encourage them to discuss the potential complications for the baby with the medication that they're prescribing, and discuss birth control and emphasize the need for a planned pregnancy. I think a lot of psychiatrists shy away from that, but I think it's a really important part of taking care of young women and older women, for that matter, with mood disorders. Rule number two, consider exposure to psychiatric illness in utero and exposure for the baby. And so many people kind of forget that this is an exposure, that a woman being psychiatrically ill during pregnancy is a danger for herself, is a danger for the baby, and is associated with poor outcomes. And so as I said, in prior days, we used to recommend stopping medication, but that's associated with a high relapse rate. And then you've exposed the baby to the psychiatric illness itself, and then usually medications are restarted kind of in an emergency setting, and the baby often gets exposed to more medications than they would have if the woman had simply continued the medication during pregnancy. Pregnancy rule number three, limit the number of exposures for the baby. So we try very hard to, prior to pregnancy, if we can, get a woman on as few medications as possible. But the rule there is that as few medications as possible that keep the woman well. So being partially ill is no help to anybody. And so I have a lot of patients who want to be on as low a dose as possible, and are kind of willing to be partially ill during their pregnancy. And to me, that just doesn't make sense. Be on as much medication as you need to stay well so that you're limiting the number of exposures for the baby. I also try to make medication changes prior to pregnancy. So I have a very wonderful situation frequently where a woman will come in and say, I'm planning to get pregnant in about a year. And I love those consults because then we can play with her medication regimen, find what works, and get her on as few medications as possible and on safe medications that we know something about. The situation where a woman presents and she's already pregnant is not the time to be making medication changes, if at all possible. Rule number four, this seems obvious, but use medications that we know more about them. And in this case, older medications generally we know much more about them. So I'll get into this in just a little bit, but I've had a number of patients whose medications were switched because they found out that they were pregnant to a very new medication that was classified as Category B on the FDA scale. And the fact is we know nothing about those medications in pregnancy, which is why they're Category B, and I'll explain that some more in just a minute. The other thing is that in psychiatry we use a lot of anti-seizure medications, and that actually helps us because there's a large epilepsy literature having to do with anti-seizure medications during pregnancy. So we actually know a lot about our anti-seizure medications, and sometimes we know more about them than we know about our newer antidepressants, for example. And basically the FDA categories are not useful at all. So, and I'll talk about that here in just a minute. And then rule number 5 is that every case is different. In other words, there really are no set rules. So you have to take into account a woman's psychiatric history, how severe her illness is, does she get suicidal, does she need hospitalization. And so a woman who started an antidepressant for premenstrual symptoms is very different from a woman who gets psychotically ill every time she stops an antidepressant. And so you have to consider kind of the totality of the history when you're making medication decisions in this population. And rule number 6 is that this is a team sport. And when I give this talk to psychiatrists, I really encourage the psychiatrist to reach out to the OB-GYNs, to the pediatrician, to talk to the entire family so that everybody's on the same page as to why we're using certain medications during pregnancy and why it's important to continue certain medications during pregnancy. So I'll turn now to talking more specifically about psychiatric meds. So one of the things that is kind of hard to understand, I think this is very interesting, I actually think psychiatric medications and antidepressants in particular are probably one of the best studied medication groups in pregnancy. And I actually think that that has to do with the stigma associated with psychiatric illness. I think many people underestimate the effects that depression has on individuals and kind of have this idea that women should be pure and natural during pregnancy, and antidepressants kind of don't fall into that categorization. And so they've been studied very frequently for outcomes for exposed infants. The problem is that certainly most of the early studies on this would compare outcomes in infants whose mothers took antidepressants during pregnancy to outcomes for infants whose mothers did not take medications during pregnancy and were in the general population. And the problem is that if you have a psychiatric illness, there's a whole host of risk factors and behaviors and other illnesses that are found in higher rates in that population compared to the general population. So for instance, smoking, alcohol use, obesity, diabetes are all more common in the psychiatric population compared to the general population. And so some of the studies that have found poor outcomes for infants didn't control for those factors, didn't control for the illness itself, and we're really comparing apples to oranges. And there have been several newer studies that have really tried to compare oranges to oranges and have compared outcomes for infants whose mothers took antidepressants during pregnancy to outcomes for infants whose mothers did not take antidepressants during pregnancy but had a psychiatric illness. And those studies, which are really controlling for the psychiatric illness itself, are very reassuring. But there have been a million studies out there, and every now and then the media will grab a headline, and the most recent bandwagon is autism, for example. And actually a study came out this week that is in JAMA and was looking at delayed speech in infants and found that there might be an association with antidepressant exposure and delayed speech. Now, what the headlines are saying is that they also found that there was no cognitive difficulties in infants exposed to antidepressants, and that's not making the headlines. They also did not control for severity of illness. And one of the problems is that postpartum depression has clearly been associated with speech delay. And so they weren't able to control for those other factors that might have been at a higher rate in women who did not, who were taking psychiatric meds during pregnancy. So you have to really kind of understand the limitations of the literature in order to be able to interpret any one particular study. So I listed some other issues here. Many women who are taking an antidepressant during pregnancy, that increases their risk for taking other medications during pregnancy. Once you're taking one, you're more likely to take others. There's a higher rate of substance use and abuse in the psychiatric population. Many women with psychiatric illness have other social stressors that can affect outcomes. In addition, there are effects of the psychiatric illness on eating and sleeping patterns, and individual effects on outcomes. And there are many comorbid medical illnesses in the psychiatric population, and there are other behaviors that are associated with psychiatric disorders. The other thing to keep in mind is that there are no studies of medications on the efficacy of treating mood disorders during pregnancy. Now, we think that treating mood disorders during pregnancy is the same as treating mood disorders during any other time period, but we know that there are big changes in metabolism and blood levels, etc., and there have been no studies really looking at the optimum way to manage women during pregnancy. So at this time, we really just kind of manage them as clinically indicated. But for instance, in the future, I'm hopeful that we'll be able to do some studies on whether or not we need to prophylactically increase certain medications during the third trimester, for example. There are no long-term safety studies on exposed infants. So the longest that we have really is about up to age 5. And again, those are reassuring, but we don't have 20 years of outcomes for exposed infants. So these are the FDA categories, and they are eventually doing away with them, in theory. And they range from A to X, and there are a number of problems with the categories. So most people think that basically going from A to X, there's an increased level of risk. And that's not true. So the categories are really based on the amount of data that we have. So, let me see if I have this. And so category B is not necessarily safer than category D. And the reason for that is that in category B, you can be placed in category B just based on animal studies. And so we may have no data whatsoever in humans, and a newer medication will be placed in category B. And then as humans get pregnant and have babies, we eventually collect that data. And then medications that were originally in category B will be classified in category C or D. So some of the medications that we know the most about in pregnancy in psychiatry are in category C and D, and are therefore we know kind of what the risks are. And so for instance, Latuda is a new antipsychotic. It's currently category B. And I've had a number of patients switch to Latuda, about which we know nothing in pregnancy because it's marked as category B. So I think most physicians just kind of forget that at some point and think B is going to be safer than D, and that's not necessarily true. There is a new rule that went into effect in June of 2015, and all new products are going to have a new label, and basically the idea is that they will eventually do away with these categories. And they're going to have sections on the label that include pregnancy, lactation, and females and males of reproductive potential. And in theory, they're going to list all the data that's out there in the literature on the label itself. Now, this is in place for new medications. It's going to be very interesting to see how they do this for older medications. Older medications are being phased in over time. I'm not convinced this is going to be a better system because I think it will make it hard to read and absorb, but we'll see what happens, so get ready for that. So, as I said, there are a number of problems with the literature, and most studies don't control for the underlying psychiatric illness, and importantly, the severity of psychiatric illness. So, psychiatric illness really has this big spectrum from, mild major depression to really severe psychotic major depression. And the further you are in the severity category, the more likely you are to have a number of other risk factors and illnesses that could influence outcomes. They also don't control for whether or not the mother was psychiatrically ill during pregnancy. Now, this is a complication because many studies kind of assume that if you're taking a medication during pregnancy, you are well. And my work actually shows that most women who are taking psychiatric medications during pregnancy are not necessarily well during the entire pregnancy. And that probably has to do with some of the changes in blood levels, et cetera. It also has to do with the fact that women and their physicians like to keep women on a small dose during pregnancy, and that can definitely have particular outcomes on the infants. So this is kind of my main point today, and so if this is the one thing that you take home, that taking psychiatric medication during pregnancy is really a marker for a population of women that's very different from the general population of women and has different risk factors and behaviors that can influence outcomes for the infant. So there have been a number of studies that have, there have been a number of risks that have been studied in infant outcomes with antidepressant exposure. There's been spontaneous abortion, preterm birth and birth weight, heart defects, persistent pulmonary hypertension, poor neonatal adaptation syndrome, autism. I now need to add speech delay to this list as of this week. But all of these have been studied. So there's a really fairly big literature out there on heart defects, and actually there have been a number of class action suits which have been actually dismissed because of lack of data supporting the idea that antidepressant exposure in utero is associated with heart defects. And this went back, I think, back to the 1990s, and there was a paper by Chambers et al. that looked at Prozac specifically and found that there was an increased risk of heart defects in infants whose mothers took Prozac during pregnancy. But there have been a couple really recent studies that were nicely done, and the most recent and the largest was by Hubricks, and this was published in the New England Journal of Medicine in 2014, and they studied over 900,000 women, and they actually were able to control for major depression and for severity of major depression. And they found that there was no association with heart defects in the adjusted analyses. So this is the nice picture. And the dotted line is 1, so the odds ratio, if it crosses 1, is not significant. And in the top panel in A, those are the uncontrolled analyses. And you can see that the odds ratios were mostly significant in the uncontrolled analyses. And then in panel B, they actually were able to control for major depression. And when they did that, most of the studies moved over to crossing 1. And then they did some proxies for severity of major depression. So they took histories of hospitalization, for example, and some other confounds that they were able to control for. And when they did that, basically the odds ratios were all completely negative. And so this is, I think, a great visual of how controlling for the psychiatric illness and controlling for severity could take what looks like a positive association and turn it into a negative one. And those of us in psychiatry think that the risk factors that could be associated with the cardiac defects include things like smoking, alcohol use, and other risk factors that could influence outcomes on the infants. In addition, there was another meta-analysis that included a population-based cohort of women who had depression and either did or did not take antidepressants during pregnancy, and they combined these 4 cohort studies and had over, close to 2 million participants. And basically, they found a non-significant odds ratio associating heart defects with antidepressant exposure. There's been a lot out there over the years on persistent pulmonary hypertension. I still have women coming in particularly concerned about persistent pulmonary hypertension. And as you know, this is failure of the pulmonary vascular resistance to decrease after birth. It's a very serious complication, and it's very rare. It's associated, as we know, with maternal smoking, maternal diabetes, meconium aspiration, C-section, sepsis, and other risk factors. You'll notice that some of those risk factors are found in higher rates in the psychiatric population, and it leads to substantial infant mortality. So there have really been 7 studies to date, and I've listed 6 of them here. 3 found an association with persistent pulmonary hypertension. 3 did not find an association with persistent pulmonary hypertension with antidepressants in pregnancy. This, I think, is very interesting. One of the more recent studies, Keeler et al. In 2011, found that a history of a psychiatric admission increased the risk of persistent pulmonary hypertension with an odds ratio of 1.3, even when those women did not take antidepressants during pregnancy. And again, I think this goes to the different risk factors and behaviors that are found in the psychiatric population. Hugh Ricks, again, came to our rescue and did another study that was published in 2015. It's the most recent study and the largest study to date, and actually looked at over 3 million pregnancies. And about 128,000 women took an antidepressant during pregnancy. And she, again, did a very nice job of adjusting for the psychiatric illness and severity, and again found that there was no significant association with persistent pulmonary hypertension. She actually included all of these compounds listed here in her analyses and controlled for them. And because women are really concerned about persistent pulmonary hypertension, I like to put things in terms that they can understand. So because it's such a rare complication, even if the odds ratio of association between antidepressants and persistent pulmonary hypertension is 6, which is what the original study found, it is about 99% of infants exposed to antidepressants will still not develop this complication if it's a real association. Now, I happen to think it's probably not a real association, but still, it's a very rare complication, and if it is real, it's extremely rare. So the most recent studies have looked at autism, and again, the studies that have found an association with autism have not controlled for the underlying indication for antidepressants, depression. And this was just published, and basically antidepressant use during the 2nd and 3rd trimester of pregnancy was found to be significantly associated with an 87% increased risk of autism after taking into account potential confounds. However, and that is kind of the title from the study. This was based on 31 cases, and this is a great example of some of the studies that get published out there and get major headlines, and they never stop to tell you that this was based on 31 cases. And the effect was persistent even after taking into account maternal history of depression. And basically, if you look at the confidence interval there, it's 1.03 to 2.97, which means it's very close to being non-significant. And in a sensitivity analysis that was restricted to children with a diagnosis of autism confirmed by specialists, the findings were consistent with those of the main analyses, increasing the validity of these results. But what's interesting is when they restricted the analyses to children who had a confirmed diagnosis by a specialist, those results were not significant. And the other children were included if they had an evaluation for autism and not a confirmed diagnosis of autism. So this is a great example of a study that is really skewing their story to fit the headlines. But if you really dig into the literature, there are some problems with it, and you need to take that into account before you believe the headlines. So let's talk for a minute about a syndrome that is real, poor neonatal adaptation syndrome. So about 1/3 of babies that are exposed to antidepressants in utero will have this syndrome. And it's really a cluster of symptoms, and it's seen in infants exposed to other types of medications, and it's even been seen in infants that are not exposed to medications. And so it's thought that it could be a withdrawal syndrome from antidepressants. It could also be a toxicity type syndrome with exposure to antidepressants. The symptoms are respiratory distress, temperature changes, feeding difficulty, jitteriness, irritability. I've never understood how you can tell if an infant is irritable. I think I think most infants are somewhat irritable. And difficulty settling, and jaundice. One of the problems with this literature is that even though I do think it is a real syndrome, there are really no blinded studies. So the studies that have been done by research assistants and nurses that know that this baby was exposed to an antidepressant. And so we really are not totally sure as to how common this is and if there are things that we could do that would decrease the risk of this syndrome. This is from one of the studies on this, and it shows that irritability is the most common symptom. Occasionally you will see seizure or EEG abnormalities, but that's very, very rare. So we really need to get into this literature and fix it if at all possible. We need a clear definition. We really don't have a great way to measure whether this syndrome is present or not. And it would be nice to be able to do blinded studies that really test whether this syndrome is present or not, and are there certain antidepressants that are more likely to be associated with it. In psychiatry, we know that certain antidepressants are more likely to cause withdrawal symptoms in people who stop their medication. So for instance, Paxil is a very short-acting antidepressant, and a lot of people will have withdrawal when they stop that medication. Some of the early studies in this area had women that were primarily on Paxil, so it might not be as common as is reported. We don't know if breastfeeding impacts the rate of this. You might think if this is a withdrawal syndrome that breastfeeding might decrease the risk of this syndrome because it's essentially kind of a tapering of exposure to the antidepressant. Also, the FDA actually recommends tapering antidepressants in the third trimester. They have based that on no studies whatsoever, so we don't know if that's safe for the mom, and we don't know if it decreases the rate of this syndrome. So we really need to do more studies in this area. So in terms of antidepressants, here are kind of my general recommendations. SSRIs and SNRIs, which are the serotonin norepinephrine reuptake inhibitors, if you don't know, are generally considered safe. There are a couple of newer medications that have just come out. I would not recommend using those in pregnancy yet, but I also would not stop them if a woman accidentally got pregnant on them. Because it's likely that they will also be safe during pregnancy, but we just don't know much about them at this point. We also consider using the tricyclic antidepressants. Those are the older medications like nortriptyline and amitriptyline. So there's a lot of data. A lot of women have been pregnant on tricyclic antidepressants. The other nice thing about them is that you can monitor blood levels with the tricyclics so you know what you're doing, and as a level decreases, you can prophylactically increase a tricyclic during pregnancy. Of the SSRIs, we know the most about Zoloft and Prozac simply because they've been around the longest. And so if we're starting an antidepressant during pregnancy and someone who is a new onset, we usually pick either Prozac or Zoloft. Paxil continues to be a question mark. There have been some studies that have shown that there's an increased risk of heart defects with it. But again, I think that literature is primarily mixed. And it's not a medication that I would automatically stop if a woman was accidentally pregnant. And as I have mentioned, the risk for persistent pulmonary hypertension, if real, is extremely small, and most women should really be reassured. To talk briefly about mood stabilizers, so there are a couple of different types of mood stabilizers. There's some anti-seizure medications, there's lithium, and then there are antipsychotic medications. And two of our mood stabilizer medications really should not be used during pregnancy. So Depakote or valproate is a known teratogen, as is carbamazepine, which is also Tegretol. So I actually do not start women of reproductive age on these medications ever until I've exhausted every other option and I know that she is not going to get pregnant. We just do not want to use these medications. These would be two medications that you would want to stop for pregnancy. And if you have a woman who's contemplating pregnancy on these medications, she really should get a consult for switching to something else for the pregnancy. So lithium, lithium makes me laugh because I just retook my my boards, to be official, and there was a question on there about that you're not allowed to use lithium during pregnancy, and actually I very intentionally got it wrong because you can use lithium during pregnancy. So lithium got a bad rap because there was an early study that really was kind of if you had a problem with lithium during your pregnancy, call us study. And it reported a high rate of Epstein's anomaly, which is what you need to know for the boards. People recently went back and looked at all lithium-exposed pregnancies and found that less than 1% of babies that are exposed to lithium develop Epstein's anomaly. So it's actually a very rare complication of lithium exposure. And one of the things to know about lithium is that when lithium works, it really works wonders. And there are many, many, many people who have very severe bipolar disorder, who get psychotically manic off of lithium, who do well for decades on lithium. And so even though lithium has a bad reputation, it is not necessarily a medication that we stop for pregnancy. And it's the kind of thing where I said every case is different. You really want to take into account a woman's history. I've had a number of very safe and happy deliveries with no postpartum psychosis with women who have taken lithium during pregnancy. Now, there are other risks, and occasionally babies will develop diabetes insipidus in utero, and you have to monitor for that. You also have to be careful about how you use lithium during the time of delivery because women can become toxic when they're dehydrated on lithium. So in general, we hold lithium for delivery and don't restart it until about a day after delivery. There has been one study looking at 5 years of follow-ups of babies that were exposed in utero to lithium and really was very reassuring. There were no cognitive issues and no motor delays and no speech delays. Lamotrigine is another anti-seizure medication that we use as a mood stabilizer. And as I mentioned, there's a large literature in the epilepsy literature looking at the safety of anti-seizure medications. And lamotrigine is a very safe medication during pregnancy. A very early study associated it with cleft palate, but larger studies that were better controlled did not find an increased risk of cleft palate. So we use lamotrigine very commonly during pregnancy. There are really two groups of antipsychotics. They're the older antipsychotics like Haldol and Prolixin, and then there are the newer, what we call the atypical antipsychotics, which are medications like Zyprexa and Risperdal. The older antipsychotics, again, we have a ton of information about their use during pregnancy. We have, more than 40 years of experience with the older antipsychotics. And really, there have been no major teratogenic effects with this class of medications. And there may be a higher rate of preterm birth and a lower birth weight, but again, those studies really did not control for the underlying psychiatric illness. The atypical antipsychotics are being studied more and more. There's more evidence for the older atypical antipsychotics, so Risperdal and olanzapine have been pretty well studied. The newer ones, I mentioned Latuda is currently category B. I would not use yet during pregnancy. One recent study found that there was a mild developmental delay in motor control in babies exposed to atypicals in pregnancy at 6 months, but that had resolved by 12 months. So we actually think that the antipsychotic medications as a class are fairly safe to use during pregnancy. So just to summarize, you want to avoid valproate and carbamazepine during pregnancy, and then consider using lithium, lamotrigine, and antipsychotics during pregnancy. I would not recommend a woman with bipolar disorder go through pregnancy off of medications, particularly if she's had any episodes of severe illness. It's very likely that she'll get ill. And at least 80% of women will relapse with bipolar disorder off of medications during pregnancy. So just to talk briefly about anxiety in pregnancy, we don't love to use benzodiazepines during pregnancy. There have been some studies associating them with cleft palate. And a lot of women will, overuse benzodiazepines. I have a colleague who calls Klonopin the world's tiniest martini. And so we try to avoid the use of regular use of benzodiazepines during pregnancy. There's a medication called gabapentin or Neurontin, which most people don't realize this, but it actually has fairly good anti-anxiety properties in a lot of people. And so I will often try to use gabapentin during pregnancy as opposed to benzodiazepines because, again, it's an anti-seizure medication. We know a lot about it, and it's quite safe during pregnancy. I will touch briefly on breastfeeding. All psychiatric medications enter breast milk. I always tell the residents so you don't have to memorize a list, congratulations, but they all go into breast milk. And I think that's such a cute picture of that baby. So one thing to keep in mind is if a mom took a medication during pregnancy, there's very few exceptions to this, but in general, if a baby was exposed in utero, there's no reason to not expose the baby with breastfeeding. Now, there are a couple exceptions. There's a medication called clozapine, which is an antipsychotic where you have to monitor people who are taking it for decreased white blood counts. So I would not recommend that during breastfeeding. And lithium is a little tricky because if a baby gets dehydrated, lithium levels can rise in a baby. So you have to have a very particular type of vigilant mother who can breastfeed on lithium. But for instance, if a woman was taking Zoloft during pregnancy, there's no reason to say, well, you can't breastfeed because the baby was already exposed. The horse is out of the barn. Don't close the door. And if the baby is being exposed to a medication where blood levels can be monitored, I usually do recommend that we check blood levels in the baby, just because it's usually very reassuring to mom and the pediatrician, but it's also just an idea of how much the baby is getting exposed. And if the baby is having some issues with feeding, et cetera, it gives you an idea of whether that might be related to the exposure or not. Antidepressants can generally be used during breastfeeding. In terms of the mood stabilizers, valproic acid and carbamazepine, in contrast to their use during pregnancy, are actually very safe during breastfeeding. And so if a woman previously had been taking Depakote and was very stable prior to pregnancy on Depakote, she can be switched back to that for in the postpartum time period, and she can breastfeed on that. Lithium can be used but requires a very vigilant mother. Lamotrigine is definitely safe in breastfeeding, and there are kind of limited studies on antipsychotic exposures, but so far they've been reassuring. So I usually recommend this. There's no evidence for this whatsoever, but most women who are breastfeeding on a psychiatric medication like to do something. And so I usually recommend that they take the medication right after the baby feeds and right before the longest time the baby sleeps, which at the beginning is never, but in theory should evolve to being at nighttime. And then they can pump and dump for the next feeding and then resume breastfeeding at the next one, and use stored breast milk for the middle feeding. I think this makes a lot of anxious women very happy, but there's really no evidence that this decreases the exposure for the baby. So, in conclusion, there's a high relapse rate for mood disorders in women who stop their medications for pregnancy. An exposure to psychiatric illness in utero is associated with poor outcomes for both the mother and the child. And the use of psychiatric medications can be safely done, but requires an individualized plan based on the woman's history and preferences. And our main goal is healthy mom and healthy baby, and I'll be glad to take any questions. Yes. So that is a great question, and it has not been examined. I regularly monitor thyroid in women with mood disorders in general, because there's actually a higher rate of thyroid disease just in that population. But I don't do extra monitoring during pregnancy, but generally almost any time I get a lithium level, which I do several times during pregnancy, I check a TSH. And I think that's just part of, par for the course. So I do monitor for it, but I don't know that there's an increased risk for it during pregnancy. I think that's wonderful. I have several patients who've insisted on going off medication during pregnancy, and we've restarted in the postpartum time period. It's a little bit of magical thinking to some extent, but again, it's kind of like that breastfeeding recommendation. It makes some moms feel better. It was mentioned, I'm actually hopeful that we're going to have a test for during pregnancy for women who are at higher risk of postpartum depression, and then because we have identified and confirmed in a couple different populations 2 biomarkers of postpartum depression. And so the ideal situation eventually will be that we'll be able to test women during pregnancy and say you have to start an antidepressant in the immediate postpartum time period. You could also consider starting them in that 3rd trimester. And they may feel better having gotten through that 1st trimester, but they'll be less likely, because postpartum depression often can start within hours of delivery, and many women describe it as kind of a curtain coming down over them. They felt different within hours. And so even starting a medication, our antidepressants really take a couple weeks to work. So you could see if they'd be interested in starting in the 3rd trimester, and that might actually decrease the rate even more effectively.
That's the method that I usually take, of trying to convince people to start before they deliver, because I know that if it takes 6 weeks to really start working,
you're there.
Do you know if there's any variation in the neonatal syndrome of withdrawal toxicity, whatever, if you're starting in the 3rd trimester versus continue to
No, there are not enough studies on this at all.
Knowing that that's the one real tangible risk, it's hard. I do try to convince people to go back on in the 3rd trimester, but then I say, okay, well, I don't really know why you stopped in the first 2 trimesters. Now we're starting in the 3rd and exposing you to the only real known risk.
Right. I know, it's really terrible, and that's why I was emphasizing that we really need better studies on that syndrome. My guess is that there's a different rate with different antidepressants. There are a couple studies looking at genetic variation of the serotonin receptor, and it appears to be strongly associated with particular versions of the serotonin receptor, which kind of makes sense. And so, you could imagine that if we knew that Prozac for example, had a much lower rate, which I would suspect it does because it's so long-acting, then we could start Prozac in women, inappropriate women, if they didn't have this version of the serotonin receptor, et cetera. So we really need better studies on that. But I agree with you, and this is kind of why I've come down to, if you're on an antidepressant, just stay on it. Just stay on it. It's much safer. Now, if someone's had very mild illness and it's questionable as to why she went on it in the first place, that's something different. But certainly for the population of patients I see, they really should stay on medication. And I will also tell you that every woman that I've taken off an antidepressant for pregnancy has relapsed. And I realize I see a very particular severity of patients, but still, it's just not a good idea. Yeah.
My other question for you is about gabapentin. I actually didn't know. One of the hardest populations that I kind of wanted to discuss. And so when somebody comes to you and is pregnant and on benzos, you start them on gabapentin and you float for a while and leave them off benzos? What's your approach to that?
So it depends on the case. And so when I use gabapentin during pregnancy, usually in the setting of someone has become anxious. So there's a subgroup of women that get extremely anxious during pregnancy. And if they are not on a benzo, I will start with gabapentin as opposed to a benzo because I think it's safer. Now the problem, this is a little trick that most people outside of psychiatry don't know about gabapentin and anxiety. They can be really, really helpful. The one problem with it is that there's this huge range of dosing. And so some women need 300 milligrams and some need 3,000. And so you really have to do this kind of experiment with how much they're taking and when they're taking it to get it to work. So it takes some futzing with. If they come to me on a benzo, I talk to them about the risks of that and try to get them to taper down. And then if they start to become more anxious in that setting, I will often start Neurontin and try to switch them. But if they're on a low dose of a benzodiazepine and have been stable and are doing well, I often do not touch it and just, like if they're on 0.5 of Ativan at night, that's really going to be a very low risk for the baby. Whereas taking them off and having them get anxious is going to be a bigger risk. Other questions? I solved it all. All right, well, thank you very much. I appreciate it.